Today's topic is good cytology preparation. It's a slide seminar. So we have chairpersons Dr. Kedar Devdar. Sir is a professor in Department of Pathology, Tata Memorial Hospital, Mumbai. And Dr. Dilip Kumar, who is a professor and head of the Department of Pathology in PMCH, Patna. The faculty who is conducting this slide seminar is Mr. Salim Pututara. Sir is officer in charge in Cytopathology Division, Department of Pathology in Tata Memorial Hospital, Mumbai. So these are the participants who will be interacting with Mr. Salim. So may I request all the students to introduce them one by one. Dr. Nikita.
Good evening, everyone. I am Dr. Nikita Singh from KMC, Mangalore, Pathology First Year Resident.
Good evening, everyone. I am Dr. Tamanna, a first year resident from BPS DMC Sonipat.
Good evening, everyone. I am Dr. Prinsa Patel, second year PG resident from Government Medical College, Maanagar.
Jayashree.
Good evening, everyone. This is Dr. Jayashree from JNMC Savangi, Vartha, Maharashtra.
Good evening, everyone. I'm Dr. Saujanya, second year postgraduate from Indian Institute, Telangana.
Good evening, everyone. I'm Dr. Priyanka, second year PG from Sri Siddhartha Medical College, Tumkur.
Thank you, everyone. So attendees, they can interact with Mr. Salim through us, through moderators, by typing their questions in the chat box and their comments in the chat box. So moderators for this session, myself, Dr. Dhanashri, I'm a part-time lecturer in International Medical University in Malaysia. And along with me, Dr. Apurva Kaya is there, who's a consultant pathologist in Shisat Pathology Lab, Shirampur, Ahmednagar. Webinar host are Dr. Anita Bojes ma'am and Dr. Sumit Gujral sir. So these are a few reminders. In case of connection interruption, low or no sound, or video freezing or video lag, kindly leave the meeting and rejoin with the same link. And if problem persists, please check your internet connection. And please answer the poll questions by typing in the chat box. And please do not send any request for annotation to the presenters. Here are some disclaimers. Few more disclaimers. Regarding our upcoming talks, next talk is on Thursday, coming Thursday on 2nd November, on screening cervical cytology by Dr. Nusrat Hussain from Lucknow. And next week, the next slide seminar is on 7th November, approach to exfoliative cytology effusion by Dr. Kamal Mehrbani. So I invite Salim sir to share his screen and start this session. Thank you.
Thank you. Thank you, Dr. Jayashree.
Thank you, sir.
Can you see my screen, Jayashree?
Yes, sir.
Yes,
okay. We can. Yeah.
Okay. So, good evening, ladies and gentlemen. In the outset, let me thank Dr. Borges, madam, for giving me this opportunity. She is my guru, and from she, I learned the ABCD in cytology, and also my colleague, Dr. Gujral, for giving me this wonderful opportunity to share my experience to all of you. The topic of my discussion today is good cytology preparation, and okay. So before going, we should understand certain things about cytological background. So optimal diagnostic cytology depends on proper and careful collection and proper processing of the samples. This needs we should have a proper standard operating procedures in the laboratory, and for accurate interpretation, the smear should be of thin monolayer quality without any air drying artifacts, especially for wet fixed smears, and completely air dried smears for GIMSA, and no obscuring hemorrhage in the smear, optimal staining quality, and appropriate quality control in every step of the cytology processing. So these are the various types of samples received in the cytology laboratory. As you can see, various types of fluids like pleural fluid, ascitic fluid, pericardial fluid, and CSF, urine, bronchial lavage, sputum, and also FNSC smears and FNSC samples, cervicogeneal smears, GI tract samples, etc., etc. All these things have been received in the cytology laboratory. So coming to the fluid samples, It has to be collected in a clean dry container, preferably in a screw capped plastic bottles, because the glass bottles can break, and it has to be in a plastic bottle with a screw capped system, and to ensure no spillage, no leakage. After collection, the sample should be sent to the laboratory as soon as possible. And if there is any delay, or if you cannot send the sample immediately, if it was collected in the midnight or something, it can be kept in the refrigerated, prefer at 4 to 8 degrees Celsius. As far as the preservation is concerned, fresh samples are preferred over treated samples. Prefixed samples, some authors recommend prefixed samples. We are not doing that. Prefixed samples using 50% alcohol is not recommended because it can precipitate the proteins, and anticoagulants such as EDTA or something or heparin added is also not recommended. So prefixation, what is the disadvantage? This can coagulate the protein, and this causes rounding up of the cells and interfere with the cell adherence to the slide. And anticoagulants added can interfere with the sediment formation, and especially it will interfere with the cell block preparation. So if what are the advantage of the fresh sample? The cancer cells are layered properly from the buffy coat layer, and better cell adherence to the slides, and better preservation and morphology. So I'll be describing, or I'll be talking about the conventional preparation or processing of the cytology smears, and I'm not touching the LBC part. So all the samples in the cytology lab is processed inside a biosafety cabinet, and it has to be a class 2 type 2 biosafety cabinet where 30% is exhausted and 70% is recycled, and it has got an HEPA filter. And in addition to the biosafety cabinet, we should also have the processing person also should wear gloves, masks, and aprons. Now, once the sample is reached in the laboratory, we have to verify the sample identification, such as patient's name and number, and also we have to also document the date and time of collection, receiving, and the sample receiving date, time, processing, and volume of the sample collected and volume of the sample received, color and consistency of the sample, temperature conditions, whether it is come on the room temperature or in a refrigerated condition, whether this sample is a repeat sample, a new sample. And CSF samples are usually collected for cytological examination. It is better to collect in cryo vials without any anticoagulants added. So what is the quantity of the sample required for optimal preparation? Entire volume or the part of the specimen is okay. People can send the entire volume, or see if the entire volume is sent, shake well the entire specimen, about 20 to 30 ml is considered as optimal, or the minimal fluid, suppose it's only 1 ml aspirate, that can also be sent, it can be prepared, or the minimal fluid tapped or aspirate can be sent. And urine usually we collect up to 15 to 20 ml, and it has to be a fresh voided sample, and CSF it has to be 0.5 to 1 ml. Now, coming to the processing, sample should be handled inside the biosafety cabinet, as I told you. When the person who is processing should wear protective gloves and all, wear the personal. And once the sample is reached in the laboratory, the sample has to be mixed thoroughly or homogenized using a applicator stick. You can see here we are using an applicator stick and mixing the sample, and facilitate this will prevent coagulation, remove the fibrin clots, and by twisting the fibrin on the applicator stick. And divide the samples in two centrifuge tubes of 15 ml capacity, and these are in a transparent plastic tubes with the screw capped tubes, and it is ideal to prevent the spillage, breakage, and aerosol formation. And remember, the tubes have to be balanced properly. Now, after that, it has to be loaded in the centrifuge, and it is centrifuge at 2000 RPM for 1 minute. And daily disinfection of the surface with the working surface with the 70% alcohol is very important, and periodic calibration of the speed and timer of the centrifuge machine is also very important. Then smear preparation technique can be a direct smear preparation. It can be cytocentrifugation. It can be, after if the sample is very hemorrhagic, we can do a saline rehydration preparation. And if it's mucoid or rubbery sediment, we can use crush preparation. Now coming to the first preparation technique, before preparing, we have to have a fixative bottle, and a fixative bottle, this is the plastic bottle with again screw capped lid, and we have to keep the lid open, and we have to etch the number using a diamond pencil. We have to etch the number on the slide, what is the patient identity number or the lab number, and after that, slowly decant the supernatant into a test tube, and using a sub stick. This is an applicator stick with a thin layer of cotton wound on the tip of the substick. Slowly take out the sediment from the bottom of the tube, and the tube should be held in a vertical position. Don't tilt the tube every now and then. And using the substick, the material is taken and it is rolled on the smear, rolled on the slide, and the slide is immediately put into in the wet condition only. It has to be put into the fixative bottle. And for the second smear, it has to be air dried smear for Giemsa. It should not be put into the fixative bottle. It has to be kept separately. Then this substick can make evenly spread smear, and it can be a monolayer because it gives a uniform spreading, and there will be minimal cell loss, and care should be taken to optimize the amount of cotton on the shaft. So if it is a mucoid material, especially the mucinous sediments and all, you can use a crushed smear where little amount of the sediment is taken on one slide, and using another slide we can crush the material. Now, if there is no sediment, we have to resort to cytocentrifugation, or if there is very scant sediment which cannot be retrieved, so it is better to cytocentrifuge. As you know, cytocentrifugation is method where cells denser than the suspended fluid is thrown directly onto the slide due to the centrifugal force, while suspension medium is absorbed by the filter card. And this results in a monolayer or well-preserved cells within a 6 millimeter diameter area. So this is a cytocentrifuge machine, and these are the funnel of the cytocentrifuge machine, and this is the filter card, and this is the slide. So daily, again, this has to be disinfected daily, and a periodic calibration of the speed and timer is necessary so as to obtain the optimal results. So the screw, this assembly is made, by putting the funnel inside the steel clips, and we have to charge the machine, and we have to run the machine, and after the end of the machine, the slide is taken, and you can see a small thin monolayer smear is prepared at a 6 millimeter area, and it is immediately, and we have to etch the area, smear area behind the slide so that we can identify which where is the smear exactly even after mounting. So thin monolayer smear in a limited area. This is the advantage. Care to avoid air drying artifacts when the smear for pap staining. And one slide can be air dried smear, so that is meant for Giemsa staining. Now, if there is hemorrhagic samples, if the smear is, if the material is very hemorrhagic, we can use saline rehydration method, and this method is for the complete hemolysis of the RBCs in the slide. So what is the principle? The physical damage caused by air drying to RBC is more than the damage caused to the epithelial cells and other cells. The rehydration with the saline leads to the rupture of RBC, but preserve the epithelial cells and other cells. So you can see how we do that. See, one extra smear is prepared, hemorrhagic smear, which is kept inside the oven at 37 degrees centigrade. And if there is no oven, we can keep it outside in the atmosphere in the biosafety cabinet only. Automatically it will dry within 2 minutes or 3 minutes. It will dry completely. Once the slide is completely dried, place the smear on a staining bar or on a horizontal position, and put saline from the side. One side of the slide, we have to put the saline from here. Slowly drop the saline on the slide without disturbing the smear, and keep the saline flooded on the smear up to 30 seconds. Just count 30 seconds, and remove the saline by holding the smear in a vertical position, and hold it on a blotting paper so that all the extra saline will be blotted by the filter paper, and put it into the fixative bottle. What we can see that the complete all the RBCs are lysed, and it is coming out of the smear. So this is the example where you can see smear without saline rehydration, where you can see lot of RBCs. There is a cluster. We cannot identify the smear morphology, the cellular morphology. We don't know whether it is malignant or normal. Once the RBCs have been removed from the smear, we can see a clear morphology. So what are the factors of drying can be done up to 30 minutes. Optimal time is 5 minutes. We should complete all the entire procedure within 5 minutes. Nuclear blurring may occur if the slides are kept more than 5 minutes in contact with the saline, and 30 seconds is optimal for cleaning the background for serous fluid. If it is mucoid like a bronchial lavage or something, and it may require up to 1 minute. If there is no incubator available, we can use room temperature. Now coming to the sputum. Sputum is another sample received in the cytology lab. It is once a sputum is reached in the lab, we have to put it in a transparent petri plate or glass petri dish, and you can examine the material. And this gross examination is very important for the better results. And we have to examine for the presence of blackish spots, blood tinged areas, and mucoid areas. And if the saliva, if the material is containing only saliva, this sample should not be collected or it should not be received. It has to be rejected, and the patient has to be asked to give again a sample which is representative. Only samples with mucoid material or blood tinged material or blackish spots, the blackish material, which will be giving the optimal results. Now, how we collect, see, we usually prepare by pick and smear method. For pick and smear method, take a glass slide, you can see the slide, and holding the slide on a vertical position, slowly pick up the material with the help of an applicator stick onto the slide, and this material can be spread with the use of the chopstick, slowly spread on the slide in a thin, even manner. And if it is very rubbery or tenacious, we can crush the material with the help of another slide, and using the chopstick, you can spread it further to make a monolayer smear. Once the smear has been made, it has to be put immediately before drying. Remember, this is a mucoid material, so air drying will not happen very as fast as in a serous fluid smear. So you can slowly put the smear without disturbing this material, slowly put it into the fixative bottle. The fixative bottle contains the fixative. So what is the disadvantage of this method? It has, we can pick up only limited material. If there is lot of material, only very little material can be picked up on one smear, and it is very tedious for screening, because making a thin layer smear from a mucoid material will be little difficult. So immediate processing and fixation is very necessary to avoid air drying and degeneration. Here you can appreciate, this is one slide. Here there are a lot of cells. We know there are some 10-15 cells are there, but whether the cells are normal cells or abnormal cells, nobody can say, because the chromatin is smudged. Chromatin is blurred. What has happened to this slide? It is completely air dried. Look at the morphology of the RBCs. You can see there are RBC ghosts, but the exact morphology is lost because of the air drying. This happened because the slide has been prepared, and after preparing, it kept a lot of time outside, and then it went to for wet fixation. See, it went into the fixative. So for pap smear or Papinicola staining, pap smear means Papinicola staining, the smear has to be wet fixed, and it has to be fixed before air drying. And look at this smear. This is a urine smear. What happened to this smear? This has got completely degenerated. The smear preparation has been taken place after a long time. So you can see again the chromatin details are very murky, details are not, crispness is not there. So it is very difficult to appreciate or read the smear properly. So we can sometimes make a mistake, because even a normal cell can show this kind of changes after degeneration. So this degenerative atypia can be mistaken for malignancy. And whereas in the center smear, this is a well preserved smear. This is a fluid smear where you can see mesothelial cells. These are the malignant cells with crisp chromatin, and chromatin details and nucleoli and everything properly. So coming to the next smear collection preparation, this is gynex smears, vagina cervix smears, FNAC smears, and brushing smears. These smears are collected during the clinical examination or during the scopy time, and it is done in the OPD or in the OT. And immediately the smears has to be wet fixed for PAP, and one smear at least has to be air dried for GIMSA. And it has to be, this GIMSA smear should not be fixed at the making area. It will be fixed by the lab people. Then smears are directly subjected to the staining, because the smears are coming in the fixative bottle. Directly we can put to the pap staining machine, and the FNAC and fluid smears are stained by both pap and see, remember, all the intervention smears, we will do both like FNAC and fluid, we will do both pap and MGG. Cervicovaginal smears will be done only by pap and Nicola staining. Now, how vaginal smears are collected? It is usually done. We are doing either we can do brush or a spatula, or we can do this soft stick. These are indigenously made small bamboo sticks with a little cotton wound over the tip, and these sticks are sterilized by autoclaving. And each one stick can be used for one patient. And this is very cost effective. This has been devised by TMH, and indigenously prepared little cotton sterilized by autoclaving. Collect using the same applicator stick, we can collect from the both exocervix and endocervix. The advantage is it is the best, thin smears, easy to spread, non-traumatic to the patient, inexpensive and easily available. Now, oral smears are collected using a toothbrush. You have to expose either you can use a ice cream spatula, wooden spatula, or a toothbrush. If you are using the toothbrush, expose the abnormal area, and just move. The toothbrush has to be wet with, we have to put 1 or 2 drops of saline into the toothbrush so that the bristles will be wet, and using the toothbrush just to make it to and pro motion on the to and fro motion on the lesion till a pinpoint bleeding appears. You can see a small pinpoint bleeding appears on the pinpoint bleeding appears on the mucosa, and as soon as that is done, just tap the brush on the slide with a slowly tap on the smear. We can see the specks, white specks are coming on the smear, and this smears, these slides are now pre-albuminized with egg albumin. So it all the material, cellular material will be adhered to the slide, and as soon as the tapping is over, lot of material appear. It has to be fixed immediately with the wet fixative. And rapid on-site evaluation is important for the FNSC smears, and this ensures the adequate cellularity of the lesional cells on the same sitting, and a repeat procedure can be obviated. This will improve rate of representative aspirates, and it is very mandatory for each and every FNSC smears. And the cost of rapid on-site evaluation is approximately 5 rupees per case. Now, what are the setup required? You need either alcohol fixative, you need 1% Toldin blue, you need glycerin and wheat slides, and we have to have a microscope. So FNS is performed by the pathologist or radiologist, and if smears are fixed by either cytotechnologist or cytotex or technician can fix the smears, or pathologist can himself do that. And smears are fixed in either alcohol for 30 seconds and stained, followed by staining with 1% Toldin blue for 10 seconds, and then it is washed and mounted with the glycerin. And check the cellularity under the microscope. This can be done by pathologist or trained cytotech, and if it is adequate, restain the smear, and it has to be sent in, it has to be washed and again in water and sent in fixative for final diagnosis with the pap staining. And if it is inadequate, again this procedure is repeated and till at least 3 times to ensure the adequacy. Whenever the adequacy is obtained, cellular adequacy is obtained, we can stop the procedure. At least 3 times has to be repeated. The process has to be done. And collect extras. This is also important to collect extras, smears or material for the ancillary techniques and for triaging. And if the entire process cost it is only 1 minute, it takes on 1 minute, and the cost is 5 rupees for this procedure. Now, apart from the preparing, and we have to collect the clinical details of the patient on the requisition form. We have to ensure the age and gender of the patient, clinical symptoms, whether the patient has any alcohol habits or tobacco habits, imaging findings, scopy findings, previous histopathology, cytopathology diagnosis, and the kind of treatment received for each diagnosis and duration, and when was the treatment finished. So this is very mandatory for making a perfect diagnosis. Then coming to the fixatives, the purpose of cytological fixative is to maintain the cytomorphological characteristics and the diagnostically essential elements of the cell to be preserved. Then what are the factors affecting the fixation? pH, temperature, penetration capacity, volume change. All these are various factors which can. So there are 2 types of fixative used in cytology. One is wet fixative and one is dry fixative. Coming to the wet fixative, the ideal fixative for cytological samples are equal volume of 1:1 proportion of 95% ethanol and ether. But this is seldom used because of the ether has the hazards. It has the flammable hazards. So, and it has got a pungent odor and hygroscopic effect. So ether nowadays are seldom used in laboratories. But the second best fixative is 95% ethanol, or maybe we can use 100% methanol. This is what is being, we are using 100% methanol at TMH, and if both the things are not available, even we can use 80% isopropanol or 80% propanol or denatured alcohol, etc. Now coming to the factors affecting fixation, smear should be fixed immediately in fixative solution, as even the slightest air train can alter the morphological features, and this is important. This is important. Remember, this is important for Pap Nicolau staining. If you are going for Giemsa staining, the smear has to be air dried, then only it has to be fixed. So for wet fixed smears, it has to be first fixed before drying, and if Giemsa staining, it has to be dried, then it is fixed. The fixation timing can be up to 20 minutes, and ethanol can be very distilled ethanol, or we can redistill the ethanol if it is containing any impurities. Now the second type of fixatives are dry or coating fixatives. These fixatives are major substitutes for wet fixatives, especially for cancer detection camps or transportation of the smears from a distant collection centers. These fixatives are available commercially, and either they are aerosols which can be applied by spraying it like a spray, or liquid base, or it can be drop. There is a dropper bottle, so you can put drops this liquid drops onto the smear. So they are composed of alcohol base and in a vase-like substance, which will do the fixation as well as prevent as a it will form as a protective coating over the cells. Even the hairsprays which are used in salons and all, this can be also used as a substitute. However, this spray should be checked on extra smears before applying on patient material. Now, the spray fixative has to be sprayed at least 8 to 10 inches away from the smear so that the smear will not be altered or hole artifacts will not be made. If you are spraying very near, the smear can be disrupted. And once after it is reached the laboratory, the spray fixative or the coating fixative on the smear has to be removed. For this, smears have to be kept in 80% methanol or ethanol for 24 to 48 hours. Once the coating fixative is removed, then it is ready for next step, that is staining. If it is not removed completely, we can see bubbling, small bubbles on the smear. So it has to be again changed. The methanol has to be changed for one more 24 hours. We can keep till the coating fixative is removed completely. Now coming to the staining, accurate diagnosis is the most important prerequisite for an appropriate patient management. This involves correct identification and characterization of the cells. And for microscopic examination of the cells, as I told initially also, the smear should be thin enough to transmit light. The smears have to be maximum thin. If it is handmade also, it has to be a thin smear, adequately fixed and optimally stained. The staining, see, remember, lot of material taking on a smear will not give you a correct diagnosis. It will in fact make a bad smear. So material has to be very optimal just for a thin smear. The staining performance varies with the various staining protocols used in different laboratories. Every laboratory may have their own protocol. So coming to the Papinicolo staining, Pap staining has been used all over the world, and this is a particular stain for cytology smears, and it has been discovered by George Papinicolo, an American of Greek descent, and who described the original staining technique way back in 1942. It consists of nuclear stain, hematoxylin, and two cytoplasmic stains, OG6 and EA36. These stains can be either readily available on ready-made purchase or it can be prepared in the lab itself. So coming to the bluing, after hematoxylin staining, all formulae of hematoxylin contains, or they contain like glacial acetic acid, or it has got an acidic pH, and the pH has to be by acidic pH has to be changed by blue by raising the pH to alkaline pH, that is above 8. This is accomplished by bluing solution, and if it is acidic pH, what happens, the nucleus will take as a pinkish purple, pinkish color. So we have to change the color of the nucleus or nuclear chromatin. We are expecting a purple color for the nuclear chromatin, so we have to increase the pH of the medium by using bluing agents. There are various types of bluing agents we can use. We'll come to that later. Now, these are the bluing agents. We are using Scott water substitute, or we can use other bluing agents are ammonia water or diluted dilute solution of lithium carbonate. These are easily preparable solutions, and the pH has to be checked. After preparing the solution, we have to check the pH whether it is more than 8. If it is not more than 8, you have to adjust the pH. Only then the bluing will work. And after reusing 2-3 times using, the pH will go down. Then you have to replenish or you have to change the solution. Again, you have to check the solution pH at each time so that you will get a proper result. Now coming to the staining protocol, this is the protocol. As you know, there is the smears are in the fixative, so it will go in descending grades of alcohol coming to the water, and then it will go to hematoxylin, because hematoxylin is a water-based solution or stain, and in hematoxylin we'll keep it for 1 minute. Then hematoxylin is washed in water, 2 changes. Then we will use the bluing agent, that is the Scott water substitute or lithium carbonate, whatever, and it is kept for 1 minute. Then again we'll wash the extra bluing agent. Then slowly we will go the ascending grades up to 95% alcohol, 10 tips each. Then we will go the first cytoplasmic stain, that is OG6. OG6 is prepared in 95% ethanol base, and we will keep 1 to 1.5 minutes in OG6, and the order of the staining, cytoplasmic staining, has to be first OG6 followed by EA36. If you are doing the opposite way, it will not work. If you are doing the mixed way, that if you are mixing the OG6 with the EA36 also, it will not work, because the method of stain attachment is on competition mode. So first we have to do OG6 followed by EA36. Then EA36 is kept again 1.5 to 2 minutes, and followed by washing in 95% ethanol for 2 changes, 10 dips each, and then we will go for dehydration by absolute ethanol for 2 changes, and then there is a mixture of absolute ethanol and xylene 1:1 10 dips, followed by clearing in xylene. Then overnight or after 30 minutes we can mount the material, mount the smears. Now coming to the staining, it can be a manual staining if the workload, it depends on the workload. If the turnover is less than 100 slides per day, manual staining is okay, it is profitable. If the number of slides are more than 100 slides per day, 100 is kept as the cutoff, and we can use a auto stainer. So you can use any company auto stainer, whichever one is suitable to you, but it is always remember the stainer has to be selected in such a way where the alcohol usage is minimal, because alcohol is very costly. So you have to take troughs with minimal alcohol usage. That will give you profitability to the lab. Now coming to the, see, what is the main advantage of auto staining? Because see, auto staining in a bulk slides can be stained the consistency, there won't be any subjective variation on staining quality, and we don't need any manpower. The machine will run the cycle automatically. Then what are the results of the pap smear? Nuclear chromatin will be stained classical blue to purple. Nucleoli display characteristic eosinophilia. Bar bodies are stained conspicuously. Mucus and cell debris minimally stained, exhibiting an unobscuring background. First counter stain OGC stains keratin to over like a brilliant orange, yellow, brown, and the second counter stain EA36 stains the cytoplasm at various shades of pink, and as in eosinophilic cells, or pale blue or green in deeper cyanophilic immature cells. Now this is a slide where you can appreciate the pinkish. You can see the pinkish cytoplasm of mature squamous epithelial cells, superficial cells. It's a pap smear, and we can see the pale cyanophilia in intermediate cells. You can see the nucleus. Nucleus is transparent, and you can also appreciate the glandular cells, glandular cell, endocervical glandular cells, and pink. And here we can appreciate a large cluster of endocervical glandular cells. You can appreciate this is an honeycomb pattern. You can see the nuclear details. They are uniform. They are in a fine chromatin, and these are all normal cells. And here we can see very deep cyanophilia of metaplastic cells. See, look at the cytoplasm. Cytoplasm is very clear, transparent. Nucleus, look at the nucleus. The chromatin details we can read at 40x. We can read very clearly. It is powdery chromatin, uniformly distributed chromatin, and even the nucleus, the membrane is smoothly round, oval, and these are very dense, and you can see the features of metaplastic cells. Here comes the orangophilia. You can see some of the cells are bright orangeophilic, showing the keratinization, or maybe little hyperkeratosis. We can see enucleated squames, which is showing hyperkeratosis. Here we can again appreciate the bronchial column. This is again, I think this is a bronchial smear, bronchial lava smear. You can see the terminal plate and cilia. This also can be appreciated. And here we can see some treatment-induced changes. The cells are enlarged, hyperchromatic, and nucleolus is looking very bad, and the nuclear membrane is disrupted, and cytoplasm is showing degenerative changes. All these things can be appreciated if the staining is proper. Now look at another case where we can see large clusters of malignant cells. Here the hyperchromacy of the nucleus, abnormal nuclear chromatin pattern, high NC ratio, and loss of architecture. Here also we can see a cluster of mesothelial cells which are arranged in a pseudoglandular pattern. Here we can appreciate a signet ring carcinoma in a fluid. If this is from a gastric adenocarcinoma, and here we can see a large cluster of malignant cells. Again, it is an adenocarcinoma. Here we can appreciate the nucleolus, chromatin details, and here we can appreciate the keratinization of the keratinizing squamous carcinoma cells. Here, this is a case of fluid. You can see the mesothelial cells, again dense cytoplasmic windows, and one of the nucleus is undergoing degeneration, where you can see nuclear chromatin is lost, or maybe it is bland. Now, it is very important, whatever stains, even if it is in-house prepared or ready-made purchased, this has to be validated. Whenever a new solution is prepared, a test round of staining should be performed using extra slides to ensure. We have to make extra slides ready for this, and these slides can be used to ensure the quality of the end results as per our requirement. So each laboratory knows what is the expected outcome of the staining. So you have to run one round to see whether the prepared solutions or purchased solutions are giving the proper endpoint results. The patient samples can be run only only if the test round shows optimal staining results. Then this is very important. This is known as validation, and it has to be documented, and you have to keep a record of the validation. Also, whenever new solutions are prepared, you have to put a big label to show what is the expiry date and what is the date of preparation. Now, what are the optimum factors for optimum staining? See, we have to do a lot of quality control. One of the most important quality control is daily filtration of alcohol grades through a tight wad of cotton. So this will remove the floating cells, remove the free floating cells, minimize the cross contamination, and care should be taken as to not to mix grades while filtering them. That means always start with a higher grade, high concentration. If you are filtering alcohol grades, you have to use 100% first, then followed by 95%, followed by 50%. If you are doing it the other fashion, what will happen? It will dilute the concentrated one. So it is very important to use the the fashion in the descending order. We have to use the alcohol grades to be filtered. Then this can be done once in a week. We can do a filtration in Wattman number 1 filter paper, and daily filtration can be with the cotton. And check the pH of ethanol. Ideal pH has to be 7. Now this is the filtration of alcohol grades and xylene, how we can do. So entire staining setup can be divided into alcohol grades before OG6, alcohol grades after OG6, alcohol grades after EA36, and xylene after EA36. So these are filtered in this reverse order, so that the solutions will not be affected badly the quality. Otherwise, you have to throw away the solution. So be careful while doing the filtration, but filtration is very, very, very important. Now this is the filtration of the hematoxylin. Daily we have to filter the hematoxylin through Wattman number 1 filter paper. Hematoxylin should not be filtered through cotton. It has to be filtered through Wattman number 1 filter paper. This will remove the stain deposits and the moisture floaters, etc. And Scott tap water substitute has to be changed after every 2 rounds of staining, so that the pH has to be maintained, so the bluing will take up properly. Now, other factors are dehydration grades, alcohol grades, and xylene should be replaced by fresh. If there is a pale murky staining, after the clearing is over, if you hold the slide against the light, you can see the water condensation, if any. And there should be a low, if there is a sharp loss of contract and microscopic water droplets in the smears, then you have to change the dehydration grades of alcohol and xylene, and it will give the proper reports, proper results. Then another thing is, we have to buy good quality alcohol, and depends on the financial status of the laboratory. So either we can certify the alcohol, or we can buy the alcohol and you can redistill also. But whatever system you are using, it has to be standardized, and you should know what is the exact staining quality. You should be able to read at the smear level. And pH of the stains have to be monitored. So pH of the stains play an important role. Ideal pH for hematoxylin, ideal pH is 3. If the pH is reduced to 2, look at the nuclear characteristics here. It is looking very pale. And if the pH is if the pH is then again we can readjust the pH by using mild acid or alkali. Then again it can regain the coloring property of the hematoxylin. So we have to stain the pH, check the pH properly. We should have either pH papers, or we can have pH meter alternatively. If the pH is increased to 6, look at the nuclear chromatin. It is looking very deeply stained. We cannot read the details of the chromatin, and this is the way it has to be. Again, after changing or readjusting the pH, we can achieve the correct nuclear details again. Now looking at the OG6, ideal pH has to be 4.5. If it is increased, 4.5 is increased to 5, or if it is decreased to 5, it will look pale or darkly stained. So again, by readjusting, we can bring back the color of the thing. And again, ideal pH for EA36 is 4.5. If it is high, the coloring or the staining reaction is very suboptimal, or if it is below, it gives the very mixed kind of a coloring reaction. So we can readjust the pH with a mild alkali or mild acid. We can bring back the exact coloring of the. So we have to apply this on certain smears and see how the things work up. So if at all some result comes, immediately you should understand this is the troubleshoot. What is the reason for troubleshoot? Immediately you have to apply the we have to repair the damage. What is the damage? What is the reason for the damage? And you can change it. Now, if there is any problem happens, in the stain slide, we can destain it, and this can be done using 1% acid alcohol. This is prepared by prepared by acid alcohol concentrated HCl 1 ml and 99 ml of 70% ethanol. So if you keep the slide after removing the cover slip can be removed by keeping the slide in xylene for some time. Then all the xylene will enhance the removal of the cover slip, and also xylene will dissolve the excess of DPX or the mountain. And after that, wash the slide in alcohol, 100% alcohol, then put it in acid alcohol solution for some time. So after this acid alcohol solution, 30 seconds or up to 1 minute we can keep. So completely destain and wash in water, then followed by again put the smear in fixative solution and restain. So this can give you proper, this can give the proper staining again next time. So coming to the MGG stain, this is very important whenever we are working on a case of leukemia or lymphoma, and also all the FNAC smears, because we know the background material is all sarcomas, all background material is very important, metachromacy is important. So for MGG stain, the smear has to be air dried. Remember, the smear collected and it has to be completely dried. Dried smear has to be sent to the laboratory for fixation. Fixation by methanol will takes place at the laboratory level, not at the collection level. So first it is fixed in methanol, and the smears are tapped in, washed in tap water, and cover the smears with working gypsum stain for 20 minutes, and then after that we can wash and dry it, and then dip in xylene and mount it with the DPX. So what happens after MGG results? You can see the various kinds of WBCs, lymphocyte, monocytes, plasmas. All these things can be identified by looking at their nucleus and cytoplasm. Different kinds of blues can be appreciated, granules can be appreciated, red granules in eosinophils, blast, pale blue, nucleolus, all these things, keratinizing squamous cells, light blue appearance or robin blue cytoplasm, epithelial cells, mucus, all things have different kinds of staining. All this, most of these things can be appreciated on the Giemsa stain smears. But remember the chromatin content, the chromatin, whether it is hyperchromatic or not, this we cannot appreciate on Giemsa. Only the nucleolus, the size of the nucleus, NC ratio, cytoplasmic staining to some extent, and NC ratio and nucleolus. This can be appreciated with Giemsa, and also the background material and metachromasia. Now look at the staining result. This is the mucin out stain, and this is the Giemsa. This is in PAP. This is in PAP how mucin stains, and this is in Giemsa how it looks like. We can see the pale purple color of mucin, pale bluish purple color of the Giemsa. Of the mucin in Giemsa. And then look at the PAP stained smear showing the keratinization by orangeophilic cytoplasm. The same thing we can appreciate as the robin blue appearance of the cytoplasm. Now this is a case of metachromasia. This is a adenoid cystic carcinoma minus cerebral gland neoplasm malignancy. You can see how the PAP stain smear, where we cannot appreciate the basal lamina material. The basal lamina material has taken a crimson metachromatic crimson color, and the globules can be easily appreciated. The diagnosis can be made easily with the Giemsa. Now this is another case where you can see the lymphoma, Burkitt's lymphoma. The plastic nature of the cells can be easily seen on PAP, but it can be most easily it can be recognized this microvacuolation in the cytoplasm and nucleolus. All this can be easily appreciated on Giemsa. Now look at the DSRCT case where the cells are looking like a small round cell here, but the metachromatic material in the background material can be appreciated very well with the Giemsa. Now coming to the MGG stain, we have to be MGG means Mac-Grunwald Giemsa. It is a kind of Giemsa only. The pH of the working buffer has to be 6.8. This is very important. So if you are checking the pH daily, we have to document it. So the pH of the solution has to be very correctly checked and adjusted, and it has to be filtered in between. The buffer solution may grow bacteria, so the bacteria will come on the smear, so we may mistake it to the bacteria belonging to the case. So it is very important to filter the buffer solutions routinely, and the working buffer has to be the pH 6.8. Now mounting we can do after the staining. We have to, the slides go through the xylene where the transparency increases, and we have to do the mounting. We can select a proper mounting media. There are two types of mounting media: aqueous mounting media and resinous mounting media. And this glycerin jelly, that is a simple glycerin, is used for rose examination at FNAC, where the smear is in the wet condition, but after the complete staining, and we have to use the resinous mounting media. It can be natural resinous mounting media like a Canada balsam, or commercially available mounting medium like a DPX. DPX is the most commonly used example of synthetic resinous mounting media. That is the Kirkpatrick and Lentram's DPX. D stands for Distrine Plasticizer, xylene, and it contains distrine 80 dibutyl phthalate, which is the plasticizer, and xylene is the solvent. Now we can use different sizes of the cover slips. Either it can be 22 into 22 or 22 into 40, depending upon the size of the smear, and it has to be mounted without any bubbles. Slowly, we should not use lot of mounting medium. We should not use less mounting medium. If you are using less mounting medium, after cover slipping, immediately after some time bubbles can appear. If you are using lot of mounting medium, the smear will be very sticky, and smear surface will become dirty, and screening will be difficult, and it will be sticking to the paper and slide tray, and it will be very difficult to handle. So we have to take optimum amount of mounting medium. And now I will go to the cases. This is the first case. I think Dr. Nigida will be taking up this first case. Dr. Nigida, over to you.
Thank you, sir. So in this particular smear, I can see it's a highly cellular smear.
Nikita, please read the clinical details first.
Yes, sir. So this is a case of 52 years old male who presented with complaints of liver mass and ascites.
This
So
is ascitic fluid smear. Okay.
yes, sir.
So now you describe.
So this is a highly cellular smear in which I can appreciate a single population of reactive mesothelial cells. These cells, the cell morphology appears smudged out. It's not crisp, but cell appears to be in cluster and singly scattered um, against a background containing lymphocytes, scattered mesothelial cells, and RBCs.
Okay, so my question is to you is, are you sure, it is a single layer smear or multi-layer smear? The smear looks single layer, or, a monolayer, or, multiple layers.
So multiple layers.
Yeah, you can see, these RBCs are at a different plane, and the WBCs are at
Yes,
a
sir.
different plane cluster. And you can see it's quite cellular, no? It is, we don't know where to concentrate. No, too many cells, too many things, right? So
Yes, sir.
what do you think what must have happened to this smear, And you can see single cells as well as a cluster, right? You can see a
Yes, sir.
cluster, right? So
Yes,
can you
sir.
describe this cluster?
So this cluster, it looks knobbly um, with
What is knobbly?
hyperchromat knobbly. The shape it has
You are trying to
papilloid.
say these are mesothelial cells.
Yes, it looks like a cluster of. I'm so
Yeah.
guessing it's a
Yeah.
mesothelial cell.
Yeah, see, this is the guesswork. See now, looking at the cluster, look at the cells arrangement. No, there is there is a tight arrangement here. I am not very sure whether they are mesothelial or there are something else. Okay, there is
Yes,
no
sir.
clarity. There is chromatin details I can to see some extent, but because of the overlapping, too much overlapping, I cannot make what this cluster is. It can be mesothelial, it can be some foreign cells, it can be malignant cells, it can be anything. Okay, and what about the background cells?
So background cells, some cells are clear, like some cells show cytoplasmic vacuolation with pushed out
Yeah, yeah,
nucleus.
okay.
I'm assuming it to be signet, like it looks like signet cell morphology.
This
And
one you mean to say?
yes,
This
sir.
one you.
Yes, sir. Yes,
But
sir.
when you see signaturing morphology, do you mean to say this is a signaturing adenocarcinoma, or it's just a macrophage? See, signaturing morphology, you have to be very clear, So the communication
Yes,
has
sir.
to be very clear. So, do you think these are malignant cells?
No, sir, I can't say.
You can't say. But see this nucleus, you can say this is a normal looking nucleus. No, you can see the same nucleus in the nearby
Yes, sir.
cell. So there is no hyperchromasia, there is no irregularity, and there is a vacuole, and the morphology is a signet ring. So these are either macrophages or mesothelial cells which are undergoing. Okay, but this cluster is disturbing for me. Okay.
Yes,
This is
sir.
disturbing for me, but the details I'm not very sure about. So we'll go to the next slide of this. What do you think of the same slide?
Uh, so the morphology can be appreciated better,
Yeah, yeah,
but then background has more RBCs.
yeah.
So
But
it looks
do you think
more.
here also the material is much more than required for a smear?
Yes, sir.
Okay.
Yes,
Now
sir.
can you please first explain me, what are the type of cells you are seeing here?
So I'm seeing mesothelial cells
Mm,
in sheets
yeah.
and clusters and few singly scattered against a background of RBCs and lymphocytes.
So look at carefully. Now, are you seeing any sheets? Are you seeing any sheets? I
So
can't see any sheets. These
in
are single cells, and these are single cells, and these are single cells. These are single cells and loose clusters, loose clusters. Yeah, single. There are no sheet. Sheet means in a two-dimensional large sheet. Somewhere down the line we'll see a sheet. So this is not sheet. This is at the time of preparation. They in nutshell, what we can say, a lot of material on one smear, right? And
yes, sir.
also, can you see this? What is this?
So that is a papilloid cluster. It looks like looks suspicious.
Okay.
But the morphology is not very clear, sir.
Okay. No. Same thing
Uh,
in Jimsa.
uh, so the nuclear no, morphology I can't appreciate, but
Yeah.
the
Uh.
cell looks very
So
tightly clustered.
what do you think what happened to this smear? Why you cannot appreciate the nuclear morphology?
So because in MGG stain, the nuclear material can't be appreciated.
You can, of course, you can
Uh,
appreciate, but
yes, sir. But the
see, I can appreciate, but I cannot read it properly. Something is wrong with this smear, right?
yes, sir.
Eh?
Yes, sir.
See, something is
Yes, sir.
wrong with the smear. I cannot appreciate. There is a cluster also here. You can see a cluster here, right? So
Yes, sir.
obviously this cluster is looking atypical or bad, but I cannot say anything. So there is no transparency, right? And
Yes, sir.
see the nuclear chromatin is very smudged. So we cannot see the details. So what must have happened? See the most common
Uh,
reason, can you tell me?
Artifact.
Huh?
so pH while staining.
The dilution pH or the buffer pH is it is more. If it is increased to 7 or something, instead of the diluted buffer, it has to be slightly acidic. 6.8 is ideal. If it is increased or decreased, this is increased. This is water. They use water with a pH more than 7, so this happens. Nuclear details will not be clear then. Okay. Now this is the same smear which is properly somebody has re-prepared from the material. Now can you explain this?
Yes, sir.
Eh? What
So
okay.
moderately cellular smear
Yeah.
um, shows
uh,
um, reactive mesothelial cells
yeah.
in singles
uh,
and few clusters.
yeah.
These cells
uh,
have moderate to
which cell?
moderate cytoplasm.
These cells means what?
These
Okay, you explained
mesothelial
them as
cells.
mesothelial. I agreed. Okay, these are mesothelial cells. Okay, there are mesothelial cells singly and loose clusters. They are having, see, they are
Yes, sir.
scattered. Okay, great. Anything else?
Yes, sir.
Anything else?
So background shows lymphocytes and RBCs.
What about this cluster, this
And
large cluster? What do you think about this large cluster in the center? See,
so these
even
are
in the
tightly packed.
previous smear also, you saw two clusters, no, which were not very
Yes,
clear.
sir.
Here it is much more clearer, right?
Yes, sir.
Ah,
Yes, sir.
so what are they showing? They are showing, very tightly packed. There is a vague
Yes, sir.
glandular pattern. Can you see the glandular pattern? See this glandular pattern, you can appreciate it here, the gland formation here. This is an acinar pattern here. If you look at very carefully, you can see multiple glandular patterns here, and all nuclear and arranged. What is the most important finding here you are seeing? Loss of architecture, no, the loss of
Architecture. Yes, sir.
polarity. So it's a papillae and a papillary cluster, and which lost the architectural pattern in a totally opposite arrangement. And each nucleus, if you look at very carefully, they are showing enlargement, and there is some kind of hyperchromasia, and most important feature is glandular
Yeah, overlap.
differentiation and overlapping. Okay, so based on this, what would be your diagnosis?
Suspicious for malignancy.
Yeah, what kind of malignancy?
Adenocarcinoma most
Yeah, but
metastatic.
see, we are looking at a case of liver mass. Patient has presented with a liver mass and ascites. Okay, and look at
Yes, sir.
this chromatin very carefully. This is a powdery chromatin. Stippled chromatin. Okay, somewhat stippled powdery chromatin. Now we'll go to one more thing. This is the look at the previous one. All RBCs were here. Yeah, you can see a
Yes,
lot
sir.
of RBCs in the background. Now what happened? Here there is no RBCs. How these
Yes, sir.
RBCs are gone?
So, lysing solution.
Yeah, we did saline rehydration we applied, so all RBCs are gone. Now, can you look at the morphology very carefully? There is a cluster here, right? Yeah.
Yes, sir.
What do you think about this cluster?
So, this looks the cluster
Tell me the
has
chromatin
acinar
pattern.
formation.
Yeah, tell me the
Yes, sir.
chromatin pattern.
Stipple chromatin, sir.
Stippled chromatin, yeah, and they are forming small acinar-like structures, small nest and acinar-like pattern, and stippled chromatin is
Yes, sir.
very, very appreciable. So, what would be your diagnosis now? Of course, we'll say positive for malignancy. Yeah.
Yes, sir.
Yeah.
Yes, sir.
So what do you go further?
So, I would ask for the cell block.
Yeah, but see, suppose somebody asks you what is your morphological diagnosis? No, we can go for cell
Yes,
block,
sir.
agreed. But what would be your morphological appreciation? See, you just said this is stippled chromatin. They are forming small nests and small acinar-like pattern. So what would be your diagnosis? Suppose you want to refine your diagnosis.
Adenocarcinoma, sir.
Yeah,
Hepatocellular carcinoma, if it's a liver mass.
yeah, see, it is not a real adenocarcinoma. Probably this is a neuroendocrine carcinoma because this chromatin pattern is, very neuroendocrine type. Okay, so if I am putting this diagnosis, I will say positive for malignancy, and tumor cells are showing neuroendocrine chromatin pattern and arrangement. So possibility of a neuroendocrine tumor will be very likely. Okay, this would be my diagnosis. And looking at the GIMSA, again you can see this is a redone GIMSA. Okay, here you can appreciate the nuclear details, and this thing nuclear details much more clearer than the previous smear. So what have you learned from this?
So that staining is forms a very important part of helping us diagnose a case.
Yeah, more than staining, even
And
the
troubleshooting.
amount of quantity of the material taken to one smear. No, we should not think that lot of material will give. This was my point. Dr. Kedar, you want to make a?
No, I think Salim, you said it very rightly. First of all, I really enjoyed your talk because those are, and for the sake of students, I will comment that those are very, very practical points regarding, staining quality, smear preparation, pH of the buffer, etc. Regards to this case, I think there are too many cells on the smear, which are making our life difficult because to read into each cell cluster is difficult. But what we have seen is that after rehydration, after saline treatment, we have got rid of the background RBCs. Then we can make out the essentially what we are looking for. Can we make out a different population of cells other than mesothelial cells? So if mesothelial cells are seen in the background, and this is a different type of population of cells which are seen on top of each other with stippled chromatin, I think then we are thinking about a neoplastic population of cells such as neuroendocrine tumor. I think that's the important point. I will also ask all the students to look at the history very carefully.
Yeah.
If you look at the liver mass and this is ascites, it may well be a liver mass, could be hepatocellular carcinoma, and ascites could be just a reflection of cirrhosis of liver with portal hypertension. There may not be actually cancer at all. So we should use our knowledge of background history, medicine, and think of the possibilities. Then second step is to note what we can see the slides, and third step is to interpretation of this myth. So I think Salim has explained it very well. It's possibly a neuroendocrine tumor. So I think that's about it. So if we can make a smear without with some lesser amount of cells, actually that will be much better. More number of cells doesn't necessarily equate to a better diagnosis. That's right. Yeah.
Yeah. So the main point was, it is too distracting because of overcellularity. Okay. And
Please.
it was
Yeah.
clear. Okay. Now coming to the second case, I think Dr. Tamanna is taking this case. Over to you, Tamanna. Dr.
Sir,
Tamanna.
thank you, sir.
Ah.
Sir, this is a case of 35 years female, routine screening for pap smear. On examination, in cervix, no abnormality detected.
Yeah. Describe the smear.
According to Sir, this is a pap smear which is unsatisfactory for evaluation due to obscuration, more than 75% obscuration by inflammatory cells, and the
Yeah.
squamous cells are not well visualized.
Yeah. So what you are telling, it's only neutrophils are obscuring, or anything else, do you think what is the material taken on one smear is minimal, or or it is lot of quantity of material is gone to one smear? What do you think?
Sir, lot of quantity of material is taken. And
Yeah. So this material, at least we could have made 5 smears, right?
yes, sir.
Yeah, okay. So if you really think, if these are handmade smears, conventional smears, right? So
Yes, sir.
suppose, we are reporting it as unsatisfactory due to obscuring, right? As per Batista, this is Batista system, yeah?
Yes, sir.
There is some. So can you tell me what is the correct satisfactory smear has to be as per Batista system for reporting?
Sir, first is adequacy criteria. In conventional smear, 8,000 to 12,000 squamous, well visualized and well preserved squamous epithelial cells
Yes,
must be
right.
present.
Right. So here there is lot of obscuring. So cellularity is very good. It may be more than 1 lakh cells, but this is obscuring due to thickness. Okay. So now we'll go to the second smear. This is a repeat smear of the same patient. Can you explain here? Is it okay for you? Is it not okay for you? What you will report this as? So you have to first say, the suitability, whether it is satisfactory or not. Come on, Tamanna.
Sir, this is satisfactory for evaluation.
Yeah. So how you understood this is satisfactory?
Sir, squamous cell cellularity is adequate and
Yeah.
the smear is not obscured.
Okay, my question is, how did you understand this is adequate? You told me 8,000 cells, are required, right? 8,000 to 12,000.
Yes, sir.
How can you ensure this is 8,000 cells?
Sir, we will look for 10 fields, 8 to 9 cells per field in conventional
Okay, so if the
at
field,
40x.
what? Sorry, you're right. Tell me, no.
So at 40x, we look
Yeah.
for
So there is a
8
mechanism.
to
Yeah,
9
agreed.
cells.
Yeah. See, 40x, at least 9 cells should be there. If your microscope is using a eyepiece of 10x and
Yes,
field of view is 22. Yeah. So you
yes,
have
sir.
to have a field of view 22. If you are using field of view 20, it has to be 10 cells, something like that. So we have a chart in front of us. Looking at the chart, we can say whether it is satisfactory. So this is satisfactory. Can you describe the type of cells first?
So these orange cells are superficial squamous cells.
Mhm.
Mostly superficial squamous cells are present.
Yeah. What does it indicate? Lot of superficial cells.
Sir, this is of reproductive age group female.
Yeah, but what is her period? What is the status of her? Which whether it's pre-ovulatory or post-ovulatory? What do you think this smears are?
Sir, this is pre-ovulatory.
Yeah, because there is lot of estrogen. That's why there is lot of maturation. That's why you are getting lot of mature squamous epithelial cells, no superficial type of squamous epithelial. Do you see anything in the background apart from that? So you can see some WBCs, right? Yeah, but very
Yes, sir.
minimal
Yes, sir.
WBCs, no. And
Yes,
what
sir.
else? You can see some bacteria started appearing, yeah, and maybe
Yes,
some
sir.
candida is also there, I suppose. Okay, so these are the little things, but basically this smear is satisfactory, but the same smear which is collected from the same patient was unsatisfactory. Yeah, the reason is
Yes, sir.
very evident. Yeah, so
Yes,
we'll
sir.
go to the. This is a high power. Well, can you explain this type of cells in the center?
Sir, this
Hmm.
this looks like parabasal squamous cells, sir.
How can you get parabasal squamous cells in a reproductive age woman? You only said,
Yes, sir.
this looks reproductive age woman because, a lot of estrogen, right? So,
Yes, sir.
do you think this is parabasal?
Uh, no, sir.
When are you
Endocervical.
expecting, parabasal cells in a pap smear?
In old age, sir.
Old age, basically in
Yes.
atrophy, right?
Yes, sir.
Yeah. So is this patient atrophy? No, no.
Endos
It is a young female, right? So what are,
endocervical cells, sir.
this is not endocervical. These are squamous cells,
Endometrial.
No,
Yes, sir.
no. This is not endometrial. This is metaplastic squamous epithelial cells. Okay. So where
Yes.
are these metaplastic squamous epithelial cells come from?
Immediate cells.
Hmm? Where they come from? Metaplastic squamous epithelial. Eh? Transformation zone. No? Have you heard
Transformation.
transformation?
Yes,
Yeah,
sir.
transformation zone there come from. Okay. So what is the presence of the transformation zone is important in a pap smear or not important?
Yes, sir.
See,
It's not important for saying this criteria is satisfactory, but
yeah.
presence of transformation zone is important to look
Why
for
it is important? Yeah, why it is so important? Because most of the malignancies arise from the
malignancies occur at
transformation zone.
transformation.
Suppose you had seen the first of this slide, can you make out there is any transformation zone? No way, because it is
No,
obscure.
sir.
Okay, here we can't see. This is a better smear, and here we can appreciate the transformation zone component as well. No, okay.
Yes, sir.
I think Dr. Kedar, sir, you want to comment?
I think you've described it well, and Dr. Tamanna also described it well. Uh,
Yes.
I think one or two. I think I will points I can say is that if we are calling some smear as unsatisfactory, we should give the reason why we are calling it unsatisfactory.
Right.
Maybe it is a
Yeah.
hemorrhage obscuring or acute inflammation obscuring the cells. And if suppose we land up in a situation where the smear is quite unsatisfactory because say, of hemorrhage, but we are seeing maybe a very few cells which are actually very abnormal, say such as HCl or something like that, then in that case, we should say that there are some atypical cells on a smear, and maybe repeat sample examination is better. So if you see any abnormal cell in an otherwise smear, what you would have called it unsatisfactory, please mention that because it alerts the gynecologist or the smear taker, and they can because mind you, we are looking for a cervical cancer screening program in a population-based screening. The idea is to detect something abnormal and not to miss, even if it is a very small amount of abnormal cells.
Yeah.
I think that's about it. So I think we can move to the
Thank you,
next.
Dr. Kedar, sir. This is a nice point. I just missed that. Presence of single abnormal cell, single atypical cell. If you identify single atypical cell, even it is a single cell, makes the smear satisfactory. Okay. The all criteria, whatever described is satisfactory for evaluation, whatever criteria it is for signing out a negative smear. But presence of a single identifiable atypical cell make the smear automatically satisfactory, then you have to mention, as Dr. Kedar said, suspicious, or askh or ascus, whatever the suspicious looking cell as per the category. So otherwise, a negative smear sign out, it has to be completely satisfactory by various means. Okay, now we'll go to the next case. I think next case is Dr. Prinsa is taking. Dr. Prinsa, over to you.
Yes, sir.
Read the case, case details and describe the
Yes,
case.
sir.
Uh,
56-year-old female with
okay.
ascites and bilateral adnexal mass.
Yeah, okay.
And this
Describe.
smears of
Explain the smear.
smear are moderately cellular, and some are atypical cells are present with hemorrhagic background are there.
Do you really think it is moderately cellular or very, very cellular?
I think it's moderately cellular.
Yeah, okay. See, to me it looks very, very hypercellular. See, look at the cellularity is too much, right? Too much cellularity everywhere, too many cells. Okay, okay. Now describe the cells. What is in the center? Prinsa, can you tell me what is this? What is this area?
Sir, many water artifacts are there.
Yeah, what artifact? Water. Water artifact won't come, no? This is some peculiar artifact, you can see, cells are taken, some shadow appearing, and this is a very, very peculiar artifact, and reason is also immediately anybody can understand what is the reason.
So in chat box, people are answering bubble and DPF.
Yeah, okay. So there is lot, no, there is a lot of air bubble. A big air bubble has come. So what could be the reason of this air bubble, Prinsa?
Sir, this slide is not properly aired, right?
No. It is air dry. There is no need of it. This is a Papanicolo stained smear. It's a fluid smear. No, it should not be air dried, right? So because of the thickness, over thickness, material is, haphazard, lot of material on the smear. So it is not a monolayer smear. It is a thick smear. So even if you are using a lot of DPX, a bubble can appear, and it is not a monolayer, right? That is the main thing. And quantity of the material is too much in the smear. So this quite often, the slides come to us, all appears like this because this air bubble effect. You cannot read. Is there any malignant cells which is gone inside this bubble? Then you have to remount it. See, sometimes remounting happens later, much later, the cells preservation also changes. Okay, then we'll go to the second. See, this is the smear, no? What do you think? It's a very low power. It's in a 4x, see the cellularity, right? Very, very cellular, right? So, can you read the morphology? What type of cells can you tell me? Prinsa, can you tell me what is the type of cells here? Any type of cells?
The morphology cannot properly identify.
Right, absolutely right. The morphology cannot be read because it is totally thick smear. Now, this is the genes of the same thing. It is in a high power. Now, can you tell me the morphology? Can you tell me the morphology? They are in clusters or single?
So this is cluster.
Yeah, there are clusters, there are single cells as well, right? And you can see something here. Can you see something here?
Yes,
What
sir.
is this?
There is a malignant ball-like structure.
Yeah, but inside that ball, you can see some peculiar thing, What is this?
Morphology cannot identify.
Yeah, this is a samoma body, right? Samomatous calcification, right? So there is a cluster, large, big clusters, but details are not very clear, right?
Yes,
It is too thick a smear. Stain penetration is not proper. Stain has penetrated, but it didn't come out. So suboptimal staining, suboptimal staining, and in the previous one was suboptimal preparation, and it is very thick and abnormally not a properly prepared smear. Now, can you tell me now? This is the repeat preparation. We store the sample. From the stored sample, we made again the smear. This time very carefully, and someone and a good preparing person paid. So what do you think these are now?
So this is a highly cellular smear, and cells are arranged in clusters.
What kind of clusters? Can you tell me the type of clusters? They are, simple clusters without any shape. Do they have a peculiar shape of clusters? These clusters have a peculiar shape, Can you tell me what kind of a shape this is known as? Huh? Is there papillary clusters?
Yes, sir.
Yeah.
Sir.
Yeah, you tell me no. It is your turn. Odisha, you can explain. What about the nucleus?
The nucleus is hyperchromatic.
Yeah, agreed. And how the nuclei are arranged, Is it crowded? Haphazard?
Yes, sir.
It is haphazard, right?
Haphazard.
And are they showing any peculiar kind of differentiation? Are they showing some differentiation? Can you see something in the cytoplasm? Vacuoles, Can you see cytoplasmic vacuoles? Yeah, here I showed here, there is a vacuole in the cytoplasm, and here it is a Zenar pattern. Okay. Apart from that, you can also see the calcification. Can you see the calcification? Yeah. This is the calcification. Yeah. We called it as Samomomatous calcification. Okay. So now can you tell me what is your diagnosis?
Sir, according to history, it may be ovarian carcinoma
Yeah.
metastasis.
So how will you report it positive for malignancy? No? And you are describing all the features as you said, papillary clusters and all, and positive for malignancy in impression. And you will also say it is showing papillary clusters with some momentous calcification. So the most probable diagnosis could be what? Ovarian. Yeah. Serous carcinoma, serous adenocarcinoma of the ovary is the most preferred diagnosis here, right? Okay. Now this is the GIMSA. Here you can appreciate the cell clusters with morphology and haphazard arrangement. Here it is also very clear compared to the previous GIMSA. So what do you want me to tell now? Which smear was better? The previous one was better or the later ones were better?
So later one are better.
Yeah. If you were depending on the previous version, could you have reported this case as adenocarcinoma?
No, sir.
No. So you will say at least suspicious, right? Here we can clearly make it, make a diagnosis, right? So what have we learned from this, proper staining, proper thickness, proper thickness. The smear should be thin layer and should not be overlapping. Yeah. And again, smear staining quality has to be perfect, right? To make. And most importantly, air bubbles. If it is thick smears, air bubbles do come, then we cannot interpret it, right? This is what we learned. Dr. Kedar.
No, I think that's very well said. In fact, there is a very nice Samoma body which can be seen here. Dr. Pinsa, Samoma bodies are not seen in all the serous papillary tumors or carcinomas. They are seen in about 40-50% of the tumors. So if we are patient to see the smear carefully at all in all the areas, and if we see Samoma body, it really helps us to get to this diagnosis, because any normal reactive mesothelial proliferation will not usually show us the Samoa body. So I think this is very important. And if we are seeing a smear which has artifact bubbles, we can't read the cytology. We should not be ashamed to say, okay, we can't get to the diagnosis. It's better to be conservative or be safe, correct our staining, than to give it over diagnosis as carcinoma. We have to be careful in calling something carcinoma, because ascitic fluid involvement of carcinoma diagnosis will straight away get the patient to chemotherapy. So we have to be careful in making these diagnoses. Yes.
Rightly said, sir. It can go either under diagnosis or over diagnosis. Both way it can happen depending upon our workload at that day. This both sides it can happen. Positive can be reported as negative, negative can be reported as positive. We'll go to the next case. This will be taken by I think Sanskriti.
Yes, Dr. Sanskriti.
Sanskriti, go ahead.
Sir,
Read the clinical details.
Sir, a 59-year male presented with pleural effusion and right upper lobe lung mass.
This is pleural effusion. Okay, yes, so you describe.
So it's a pap smear with a low power view. We can see a cellular smear with epithelial cells in clusters and discretely.
Yeah.
Some epithelial cell we can see.
Yeah.
Individual cells are large cells with moderate to scanty cytoplasm scanty green cytoplasm, and the nucleus is centrally placed with
Yeah.
irregular nuclear border.
Yeah. What about this large cluster in the center? You think they are what type of cells they are? This cluster or this cluster?
So,
Or maybe you can describe your morphology pertaining to this single cell. Can you tell me the morphology?
In the cluster, sir.
Okay, single cell also the same thing, no? So you can describe
Yes,
the
sir.
morphology.
With
What about the cytoplasm? Do they have cytoplasm? They have, right?
yes, sir. With moderate
They do
amount of
have.
cytoplasm.
Yeah, but what is the staining they have taken?
So green means.
Can you see green? I can see reddish. Is this green or green? Can you see the nucleus in this cell?
Yes, sir.
I can't see the nucleus.
So
We are
that
presuming the nucleus, no?
Okay.
Okay. Look at, I will show you another one, another single one. Look at this single cell in the middle of the RBCs, right? Yeah. So can you see which is cytoplasm, which is nucleus?
No.
No.
Both are having the same staining, right?
Yes, sir.
What kind of a color? It is some reddish color,
Reddish
right?
color. Yes, sir.
Actually, mesothelial should have been what color? You can see a mesothelial cell here, no? Yeah. What should have been the color of the cytoplasm?
Sir,
Staining reaction.
orangophilia, sir.
Orangophilia, mesothelial cell. No way.
No, sir. Mesothelial cell will take the normal.
Cyanophilic, no? Cyanophilic stain, no? See, you know, this greenish blue, bluish green color of the cytoplasm, right? Nucleus is purple, right? It is central, right? So what happened to this cell? This cell and these clusters. What happened to these cells?
So irregularly placed.
Yeah, but why they are appearing in a different color?
So taking the keratinization means.
No. How keratinization will happen? Samskriti. See, these are mesothelial cells. No, mesothelial cells will not keratinize, you know. See, keratinization will we use the word we refer to squamous epithelial cells.
Yes,
Yeah. Here we are dealing with the probably mesothelial cells. I'm not sure what cells these are in the center. So we are presuming they are mesothelial cells. No. So what could have happened to these cells? You know, they look like very different. You know, they look like keratinized. No, you only said it is keratinized.
So
no?
dry, maybe dry artifacts.
Yeah, air drying, no? So air drying. This smears are air dried, then it went to the fixative, right? This was actually a wet fixed smear. So before going to the fixative, there is a fan or something, whatever happened. This smear air dried, then it went to the fixative. So whoever is made the smear was not very careful. So what is the result happen? This is known as amphophilia. Both cyanophilia and eosinophilia together in one cell. Look at the RBC morphology, lost morphology. No, we don't know what they are. See, most of the cells are showing nucleus, but which is cytoplasm, which is nucleus, that differentiation, the level of cutting off where is the nucleus, where is the cytoplasm is not very clear. No, chromatin is not very clear. So based on this smear, what could be your diagnosis?
So we are dealing with a carcinoma, maybe a squamous cell carcinoma.
Why squamous cell? No, we described them all mesothelial cells. No, where is the squamous cells in this?
I can see the tadpole cell over there.
Where is the tadpole? I can't see. Where is the tadpole? I missed a tadpole here.
It's in the
Can you tell me? Lower end, mein?
Lower left, huh?
This one you meant to say?
Yes, sir.
No. This is not a tadpole cell. This is just a altered morphology of mesothelial cell. Okay, you can see binucleation in the nearby cell. These are all mesothelial cells. But this cluster, I am not very sure what type of a cell. So based on this smear, can you give a diagnosis? That is my first question. Is it adequate? Is it satisfactory? It is not. No. What is the problem here? So I would report this as unsatisfactory for evaluation. I would say the smear is cellular, properly cellular, well distributed. Okay, distribution is also okay.
Yes.
Smear thickness is also okay. So, but what is happening? Singly occurring in clusters of cells with indistinct morphology, no, indiscernible morphology. So it is unsatisfactory. So as Kedar sir said, whenever we say unsatisfactory for evaluation, we have to explain the reason. The reason for being unsatisfactory is they are air dried, marked air drying artifacts, right?
Yes, sir.
Okay. Okay. Now go to the same case. What is happening here? Here also thick areas, no? Thick areas.
Yes, sir. The nuclear morphology is not clear.
Not clear at all. Now, again, we prepared, from the repeat preparation done. Now what is happening? Here the clarity is okay. Can you see the clear?
Yes, sir.
Yeah. What
Yes.
kind of clusters? There are a lot of clusters. Yeah.
Yes,
Can
sir.
you explain the morphology now? Is it squamous? Keratinizing squamous?
Sir, there is no orangophilia.
Not
So,
only orangophilia, na, see, forget orangophilia.
okay.
Can you call this squamous cell?
3D
First of all,
clusters.
these are clusters, right?
3D clusters. Present in the
Okay.
3D clusters.
Okay.
So not
can
squamous, there appears to be
yeah,
mesothelioma.
it is not squamous. No, there is no squamous shape. There is no polygonal shape. There is no, squamous, pearl formation, no cordite forms or anything. So basically, these are not squamous, but these are epithelial cells, right?
Yes, sir.
These are epithelial cells, and they are showing nuclear atypia, right?
Atypia.
What is the nuclear atypia they are showing?
Sir,
How we can say they are nuclear atypia? Because we know the normal cells look like this. No, see, there is a normal cell here, right?
Yes, sir.
It is having abundant cytoplasm and the nucleus is with a fine chromatin.
Fine
But
chromatin.
look at here, look at the chromatin here. It is hyperchromatic,
Hyperchromatic. Irregular
irregular
nuclear border.
irregular nuclear borders and irregular nuclear chromatin amount and distribution also. And what is the kind of differentiation? Can you see some of them are showing cytoplasmic vacuoles, right?
Vacuolation, yes, sir.
And some of them are showing a cinar gland-like pattern, right? Gland-like
Yes, sir.
pattern. So what could be your diagnosis? Is it positive for malignancy or negative for malignancy?
Sir, positive.
Positive for malignancy. So then what would be the next step? Is it carcinoma or just some other malignancy? We described
Maybe
this.
metastatic.
Yeah, we described these are all epithelial cells, right? So
Yes, sir.
obviously it is carcinoma, right?
Carcinoma.
So what kind of a differentiation this carcinoma is showing? See, I showed you the
Sir,
vacuoles and
cytoplasmic vacuolations.
yeah,
Maybe adenocarcinoma.
secretory activity and a cinar pattern. So we will call it as positive for malignancy, metastatic
Malignant effusion.
adenocarcinoma. Okay. Now, can you tell me what was the problem with the previous smear and this smear? If you had the previous smear, we would have
Sir, maybe the pH is high.
Not pH. I explained you. It is air dry, right?
First one is air dry. The second one, the pap smear.
It was a thick smear, no?
Yes, sir.
Okay. So it has to be thin enough, and there should not be any air drying artifact. Okay, Dr. Kedar, please.
No, I don't have anything to add. I think this is this last slide actually is very good compared to the first two. First two did not give us any clue or no diagnosis possible, whereas this is much better preparation. Yeah.
So the idea of this particular case was, immediate fixation. Okay, air drying artifact can cause, a lot of trouble, and probably the smear become unsatisfactory.
Yeah.
Okay, we'll go to the next case. This is case number 5.
Sir, pertaining to this case, audience wants to know where is the acinus formation?
Yeah, okay. I'll explain. So there are, small clusters with, small acini here, small glands, small microglandular formations. Here you can see an acini. Yeah, and here also you can see a formation. Here you can see a beautiful acinus. So this is a glandular pattern basically, and individual cells are also showing focal areas of cytoplasmic vacuoles. Basically, it is a carcinoma. It looks like an adenocarcinoma. And so here there is a single cell with a very large cytoplasmic vacuole. So, I think it is also here again a acinar pattern, right? A acinar pattern means a gland pattern, a microgland. So we'll go to the next case.
Thank you, sir.
Okay, number 5 is, Jayashree.
Yes, sir.
Yeah? Jayashree, please take over.
This is a 48-year-old male. Complaints are cough with expectorations, right upper lung mass, and this is a sputum sample.
Okay, please describe the smear.
Sir, for me, this smear is unsatisfactory as there are, I can see some squamous cells in the slide.
Yeah.
And I cannot see some like other cells which are which has to be present, like bronchial epithelial cells and certain alveolar macrophages. So
what is this material then? This is sputum.
No, sir. I think this is saliva.
Saliva. Okay. So in sputum, are you expecting bronchial columnar cells?
Sir, alveolar squamous cells and alveolar macrophages, I'll
expect.
Yes, sir.
Okay. So here we are seeing lot of squamous epithelial cells probably arising from saliva.
Yes.
So why this has happened?
So it can be because mm,
So if this was saliva,
diluted,
if
sir.
listen, if this was saliva, first
Yes.
of all, why we did accept this? We should not have accepted, no?
Yes, sir.
So we should have given a macroscopic, naked eye checking whether it is saliva, whether it contains any sputum elements,
Yes.
like mucoid material, thick, opaque material,
Yes.
blood tinged areas.
Yes, sir.
So this is just a frothy thing from which somebody made a smear,
Yes,
right?
sir.
So obviously, very clearly you explain it is showing only large differentiated squamous cells from upper this aerodicity or from oral cavity, and it is not showing it is satisfactory or unsatisfactory.
So unsatisfactory.
Unsatisfactory. When we say unsatisfactory, we have to specify the reason. What could be the reason?
So there are no the desired cells, like there are only oral
No,
cavities.
you have to be very specifically, you have to say this is description part you said is showing all squamous epithelial cells, vagara. And now end of the report you have to put an impression telling that this is unsatisfactory for evaluation due to absence of pulmonary macrophages. See, bronchial epithelial cells are not usually expected in a sputum. It is usually seen in bronchial lavage or bronchial brushing. Very rarely you can get in sputum as well, but usually, especially if it is post-bronchoscopic sputum, you can get a lot of bronchial columnar cells. But otherwise, the adequacy criteria on sputum is based on number of pulmonary macrophages. Do you know how many pulmonary macrophages are needed for that this can be satisfactory?
So 10 pulmonary macrophages.
No, there is no cutoff value. Okay, there is no cutoff value. Every field has to be there with a large number of pulmonary macrophages. Okay, now this is another field of the same.
So here I can see only polymorphs, and there are no other cells, like there are only inflammatory cells present here.
Yeah, there is one squamous cell. Yeah.
Yes, sir.
Squamous cell.
Yes.
But what is absent here?
Sorry, sir.
What is absent here? Pulmonary macrophages are absent, right?
Yes, sir.
Yeah. Okay. Now this is the same patient. We collected a proper sample, checked and all. Now can you explain this?
Sir, there are squamous cells present, and there are macrophages are also present.
So you have to quantify them, no? Squamous cells, how many? Macrophages, how many? Is there are many squamous cells or many macrophages?
No, sir. Macrophages are more.
Squamous cells are?
Two, sir. I can appreciate two.
Yeah, less,
Yes,
so there are very occasional squamous cells and many pulmonary macrophages. No? What does it indicate? It's a properly collected, properly prepared smear, right? Sir. Yeah. So this is satisfactory for evaluation. Based on this smear, I would say this is negative for malignancy, right? Yeah. Okay. Kedar sir, you want to?
Again, I think what is happening is Salim sir's first talk and has lot of clues and hints for all of us when we see the cases. The answers to the cases are hidden or are explained in the initial part of the talk, and I really appreciate that. I think I don't have anything to add in this case. Salim, we can go on to the next case.
Okay. So this is the last case. This will be taken by two persons. Okay. So we'll go to the next case. So my primary aim was to that any sputum sample, usually in every laboratory sputum is given as saliva. So patient is not explained what is the sample, and even the laboratory personnel is also never checked what is the sample they receive. They just make a smear from the saliva and it will appear like that. So we have to have a pre-check whether it is really sputum or not. This is very important so that we'll get a proper pulmonary macrophages for making adequacy. We'll go to the next case. This will be taken by I think Jayashree. Sorry, no, Saujanya. I think Dr. Saujanya and
Dr. Priyanka, sir.
Priyanka. So first, Dr. Saujanya. This
Thank you, sir. 58 years female who presented with leukorrhea. We got a pap smear. Pap smear study is unsatisfactory for evaluation as it is like completely obscured by the blood and blood elements. In the cells, in the background, we can see few cells, but they are overlapped. And we can see nucleus enlarged. Either it can be because of the drying artifact.
Right? Okay. Do you think they are malignant? Is it in cluster or single?
These cells arranged in clusters show nucleomegaly, but we cannot comment on malignancy.
Right, Saujanya. See, there is a cluster in the center and there are some single cells, Okay, there is single cell and there are some clusters. And we know, we have given the clinical history. What is the age of the patient?
It is 58 years old.
58-year-old female. So what kind of cells are usually expected on a 58-year-old female?
We can expect parabasal cells and basal cells, along with a few superficial squamous cells and intermediate cells.
See, you can't get basal cells, See, basal cells are never shed, unless, you are very traumatically collected, you may get one basal cell. But, basal cells are never ever seen in the pap smear. And again, you are telling, she's a 55-year-old female, right? And can you expect superficial squamous cells?
Yes, sir.
When you get the superficial squamous cells?
More common in reproductive age.
Exactly. When there is estrogen, no? What happened to her estrogen in this patient? She's 55. She's
postmenopausal.
Postmenopausal. So what will happen in postmenopausal status? Patient will undergo atrophy, basically cervical atrophy,
Okay.
Yeah. So what is atrophy? Can you explain me what is atrophy? Define atrophy.
Like ovarian production of the hormones will be decreased and there will
by
be
definition, what is atrophy? What is atrophy? Atrophy means decrease in the decrease in the size of an organ or a tissue due to decreased number of cells. Yeah, that is atrophy. Here, the number of cells are decreased because there is no further proliferation of the squamous epithelium. There is no further maturation. So it is 1 or 2 layers of only upper and lower layer cells. That is the parabasal cells, right? This is what is expected. But as you clearly said, it is showing air drying artifacts and the morphology is not very clear. Okay. Now we'll go to the second smear, the second part of another field of the same smear. And this, other person may explain. Dr. Priyanka can explain. Priyanka, please explain.
Yes, sir. So in this slide, we can see a cluster of cells, almost arranged in a honeycomb pattern. So I consider it to be an endocervical cluster. And there is squamous metaplasia because the cytoplasm is showing orange-philic changes. And then in the background, it shows lots of hemorrhages and
Stop. Metaplasia because there is orangophilia.
keratinization.
See, we will get squamous cells only because it is cervix, Yeah, it is pap smear. Squamous cells will be, there are a lot of RBCs here. And she's a 55-year-old woman. So do you really think you will get glandular epithelium, in large clusters in a atrophic woman?
No, sir.
What will happen to the endocervix or endocervical epithelium in an atrophic woman? It will be deep inside the endocervix, right? There will be retraction of the endocervix deep inside. So you don't get endocervical cells. So these are basically parabasal cells, right? Sheets of squamous epithelial cells, parabasal. They are not. See, if you are sampling the endocervix only properly, you will get metaplastic cells and endocervical cells. So what happened to these squamous cells? What is their morphology telling? Is it overlapping?
It is overlapping.
Overlapping. Yes, what about the nuclear features? Can you read the nuclear features? I mean, chromatin, fine, crisp, powdery. Can you explain me the chromatin? Hyperchromasia, normal chromasia, irregular chromatin. What do you think their chromatin is?
Fine chromatin, sir. Like I cannot appreciate it very much.
Why you cannot appreciate? What is the reason you could not appreciate? Why?
There is a lot of hemorrhage and inflammatory cells obscuring, sir, and I also
Agreed.
find
Agreed.
some air
Apart
drying
from
artifacts.
air drying artifacts. There are three things in this. There is air drying artifacts. There is obscuring hemorrhage. There is obscuring inflammation, and there is a sheet of cells which appears to be parabasal considering the age of the patient, but the exact nuclear details are not discernible. No, we cannot decipher or we cannot clearly explain the nuclear details. As in the case, you felt they are metablastic, somebody felt it is glandular, but glandular is not expected in this case. So whether they are malignant or not, we cannot explain because nuclear details are totally blurred. Yeah, blurring features because of air drying. So another feature, this particular case, actually this came in the 1 week back, just 1 week back. This is an outside stain smear. See, this is an outside stain smear which came for our opinion, second opinion to Tata Hospital. So the outside report has gone as carcinoma. Okay, so do you really think this is carcinoma? Do you really think it is carcinoma? It may be, it may not be. No, we don't know because the details are not very clear. Chromatin details are not very clear. It appears to be more normal looking, but I cannot make a decision based on the nature of this. So what would be my diagnosis or your diagnosis? Priyanka, what would be your diagnosis at this level? Satisfactory or not satisfactory? Yes,
Unsatisfactory.
correct. Unsatisfactory for evaluation. Then you have to say the reasons, no? What would be the reasons? Due to?
Sir, obscuring factors, sir, inflammation, hemorrhage, and air drying artifacts.
Marked air drying artifacts, right? Then what would be your comment? What you will ask for the patient? Okay, you go back. No need of further testing, or what you say? What you will give the advice to the patient? What should be done now? What can we do? Yeah, oh, that's it. Somebody's telling you near to you. Who is sitting with you? Repeat examination. No. Priyanka, you are explaining. Yeah.
Yes, sir. Repeat.
We have to do a repeat test, right? Okay. At least in this repeat test, this thing should not be there. Okay. Now we did the repeat test. Can you explain? Who is the first? Saujanya, can you explain this? Saujanya only, no? Saujanya only, no? Yeah, Saujanya.
Yes, sir.
Yeah. Is it okay now? Clear? Clarity?
Yes, sir.
So morphology is very clear. What kind of a sheet of cells these are?
We can see parabasal cells,
Correct.
sir,
These are all
arranged
parabasal cells.
in the back.
Yeah, they come in sheets. Parabasal cells are flat monolayer sheets. Now you can see monolayer. There is some technical haphazardness, but otherwise they are all sheets, right? You can see the chromatin details very carefully, right? You can see clearly the chromatin details. And look at the chromocenters, small nucleoli. Everything can be very clearly seen, right? Nuclear details are seen. You can also see lot of debris, cellular debris. This is known as the this blue blobs in atrophy. See the cells without nucleus. They become cellular bits. So they are known as atrophy, senile atrophy. Basically blue blobs. So you can see many singly occurring, many sheets of parabasal cells. The nuclear details are very, very, very clear compared to the previous one. So what we have learned from this? So okay, what would be your diagnosis in this, Saujanya, based on this smear? This is a repeat smear done at Tata Hospital. So can you tell me what is the diagnosis on this? This smear is satisfactory for evaluation or not?
Yes, next smear is satisfactory for evaluation.
Correct. Satisfactory for evaluation.
Can actually see inflammatory cells in the background.
There is inflammation. Yeah. So what will be your first diagnostic line? Is it atrophy or a normal, otherwise normal? So I will add a first atrophy because large number of parabasal, predominance of parabasal. So my first diagnostic step will be atrophy. Second diagnostic step will be, as you said, reactive cellular changes associated with inflammation, right? What will be my final impression step? Negative or positive? What?
Negative for intra.
Negative, no?
Negative for
intraepithelial lesion or malignancy. Then I will also add reported as per the Batista system 2014, right?
14.
This will be my diagnosis. So the idea, sir, Dr. Kedar, sir, kuch bolna?
I think this is good. I think the most important distinction, if we are trying to distinguish between atrophy and a high-grade cell, is coarseness of the chromatin. Atrophy generally will show us finer or light chromatin, whereas HCell, SYN2 or SYN3 cases will have a coarse chromatin. And atrophy postmenopausal lady is one of the most challenging area for diagnosis. In fact, on a lighter note, I will tell you that this is the smear which will be kept in any examination. And it is really, if you really have studied it well, then you will have courage to call it negative NILM smear. So this is something to know about. But I think Salim sir has explained it actually quite well. Salim, I think this
Thank you,
is
sir.
this is all.
This is the end of the cases, and I will go to the my take-home message. This is my last slide of this thing.
Yes, please.
To conclude, collection, preparation has to be optimal. So we have to be very careful about the standard operating procedures pertaining to the lab, so that your smear will be proper. And quality control needs to be in place at each level of the smear journey. From the collection till the submission and reporting. Standardization of the staining is important. Awareness of troubleshooting and repairing the damage, that is also very important. Technical staff needs training and proficiency assessment, and every month at least you check how proficient they are making good smears and all. Careful screening and interpretation is a must. Just jumping into a diagnosis and making a wrong diagnosis is not expected. And all these features leads to an accurate diagnosis. If you are paying attention to all these levels, we can make accurate diagnosis and thereby appropriate management. So I think this is the end of my slide. So if there are any questions, I can take up the questions.
Thank you, Salim. I think let me take half a minute to actually thank you for your very detailed and very groundwork, day-to-day practice lecture, and very informative cases. I also thank our students, Dr. Nikita, Dr. Jayashri, Dr. Saujanya, Dr. Tamanna, Dr. Prinsa, Dr. Sanskriti, and Dr. Priyanka for participating in this. This has been a very good effort on all of our part. So, Dr. Dhanashri, if there's any comments, please let us know. Yeah.
Yes, sir. There's one question from Dr. Urvi Parik. She says, how can we change the pH? Which acid or base should we use for adjusting the pH?
Okay. So we have, we have already described in my talk. I have described, see the Scott tap water or the blowing agent has to be above 8. So first you have to check daily checking of, two solutions. We daily check two solutions. One is, pH of the Scott tap water or the blowing agent basically, and we also check the pH of the buffer, working buffer of Jimsa, because these are continuously used. If there is any alteration, it can result in. So if there is a change in the pH, we can readjust with a mild acid or mild alkali. You can use 0.1% HSIL, or you can use 0.1 normal NaOH solution. So add one drop or minute drop and again recheck the solution. It will adjust the pH. So this is the way it has to be done. So you have to have a pH meter for this. So and both of the solutions will be, every lab will keep this alkaline and this solution to adjust the pH.
Right, so thank you, sir. There's one more question. How to differentiate if it's epithelial or mesothelioma or stromatolite cells on FNAC slides?
Okay, Dr. Kedar, you want to answer this?
Oh, it's a difficult matter. So if see, when you talk about FNAC, that means we have actually targeted some kind of a mass or a thickening in that particular area. Generally, we face a problem of mesothelial cells and epithelial cells in ascitic fluid or pleural fluid, in which case we have to look for skirting or the placement between the cells. Usually reactive mesothelial cells, I mean, they can be of variable size, but usually they show a circular nucleus. I think that's, to me, the more important thing. Whereas epithelial cells can show overlapping, can have irregularity of the nuclear membrane. But that is in the fluids. As regards to FNAC, if there is an abnormal mass and we have targeted that through FNAC, then chances of it being malignant are actually high. If you have a biopsy, if you have or cell block preparation, then we may need actually immunohistochemistry to separate between epithelial or mesothelial cells.
Right. So basically it is, you need a cell block, or, if it is fluid, you need a cell block and, differentiating markers for all these things. But morphologically, the basic groundwork, we have at the time of training, you have been taught what are the features of epithelial features, what are the features of, this is Dr. Kailas was telling the windows and, microvacuolation at the periphery, various mesothelial architectures. So over a period of time, you will be, proficient enough to understand which is mesothelial cell, which is non-mesothelial cell, and which is a glandular cell, which is a non-glandular cell, which is a sarcoma cell or non-epithelial cell or epithelial. All these things, over a period of time, especially JR1, JR2, JR3, by the time JR3, or even when you become a senior resident, you will be learning how to understand. So this is the basic pathology, morphology based assessment. And there are cases where we won't be able to appreciate it at all. They look abnormal, or they look, to differentiate between epithelial and non-epithelial may not be possible. So in such a case, as sir said, immunohistochemistry or cell block with immunocytochemistry will be, is the only way to identify. Otherwise, we will just resort to say positive for malignancy, cannot characterize further. Well, that will be our report.
Okay, sir.
Okay.
Then how frequently alcohol should be changed in case of pap smear?
Alcohol of the staining setup. Yeah, see, there are alcohol, used for fixation, alcohol used for staining. Alcohol for fixation, we can reuse it, recycle it, because, see, alcohol is a very costly substance, so we can recycle it, at least for, 1 month you can recycle it, and, you can fixation, it will fix it. Okay, you need not go on changing, but obviously it has to be filtered every use, second patient, you have to filter the alcohol, and, a fresh one has to be given, fresh filtered one has to be given, otherwise there will be some contamination problem from other case. And secondly, as far as the staining setup is concerned, you can see the color of the alcohol. It look murky, it look, very, very foggy appearance. Or, see, usually we keep a cutoff of changing after 2000 case slides. So our 2000 slides, come either, just before the 5th day or something like that. So usually end of every week, we change this kind of things. So we set up our target like that. So every lab has to set up their target when they can change the entire set of, alcohols. Usually we may be changing one or two, one which are, one which are spoiled, or one which are not giving. See, we will identify, okay, this particular alcohol grade is not proper, it is foggy, and xylene is, got mixed with water content, so it is looking very murky or, opaque. So, that changes will be there. Apart from that, at the end of the second week, or at the end of the 2000 slides cutoff, you can decide, 2 weeks or 3 weeks in your lab, whichever one. So in our laboratory, we change at the end of the weekend. So we will change with a fresh alcohol grade, so that, it can be reused. I mean, it can be better.
Right, sir. So I guess these were the questions in the chat box. Anything
See,
that I
listen,
missed?
1 minute. This 2000 I was telling, is applying to our setup. So, nobody should take it as a standard for them also. So it can be 100 for them, or it can be 1000, depending upon their availability, their workload, and remember, all the stains and jars should be kept in lid. You have to keep the lid when it is not in use, so that there won't be any dust falling into that. There won't be any water absorption. See, from atmosphere, these are all hygroscopic. So they absorb water from the atmosphere also. The grade will be destroyed. So you have to keep it in. If it is not in use, it is better to keep in the fridge, if there is a extra fridge for that. So, this is very important, right?
Right, sir. So
Excuse
those
me,
were the
ma'am,
questions.
I have one question.
Yeah, please go ahead, Tamana.
Sir, in WHO Bethesda system of reporting book, there's the table given for calculating cellularity
Exactly,
for
exactly.
liquid-based preparation.
Yeah.
But how should we calculate the cellularity of conventional preparations?
So it's everything, it will be one and the same, no? Because, they have taken into 3 parameters. One is the FOV. FOV means, field of view. Okay, field of view is 22, yeah? And you are using 40x objective, right? And, the eyepiece power is 10x. If the eyepiece power is 10x, your field of view is 22, and you are using, 40x objective, then one field should have at least 9. If 9 cells are there, then it translates into not more than 10,000. Okay, if 10 is there, it will be more than 10, 12,000. If 12 are there, then it will be 25. So this is the only way we can do. So there is, if you are sitting and counting the cells, we won't be able to report 2 cases in a day.
Thank you, sir.
You're welcome. And you can put that thing in front of you. I mean, that that table, where you are reporting, so you will be able to go on looking at and, study it very well. So they have given in various levels, 4x, what should be, 10x, what should be, 40x, what should be, all this, given in the table. So I stick to that 40x thing. It is easy for me. I'll just see, out of at least 10, 15 fields or, 9 cells at least present. This is the way I do.
Yes, thank you, sir.
You're welcome.
Okay, I think may I just say that we all must thank Shruti for for flawlessly conducting and her constant support for this program. She has been the backbone of our program, and from Tata Trust side, she does it very well. I also thank Dr. Apurva Kale and Dr. Dhanashri for moderating it well, because they both carried the students very well. I'm seeing that they made students comfortable, and students participated in our program very nicely. So thank you, Dhanashri, and thank you, Dr. Apurva.
Thank you, sir.
Thank you, sir.
You can make final comments, please.
Right,
Yeah.
sir. And audience is also thanking both of you regarding this excellent talk, very informative talk. And thank you, Kedar sir, for your valuable inputs also regarding all the cases.
Thank you.
And thank you, Dr. Haidar, from my side.
Thank you,
You supported me, and yeah, thank you so much. And thank you, Dr.
Very informative and very practical tips. Thank you so much. Thank you. Yeah.
Thank you, sir.
Yeah.
So I just share my screen regarding our next slide seminar.
Yeah.
So is my screen visible? Salim sir, I request you to stop sharing.
Yeah, okay, 1 minute. Why did I stop sharing? Yeah.
Yes, sir.
Okay.
So next we have the upcoming talk is on 2nd November on screening cervical cancer. So faculty is Dr. Nuzhat Hussain. She's from Lucknow. And this is the QR code for our Telegram app. Okay, so this QR code will redirect you to join this group so that you can attend all these talks on that. You get all